All right. Can you guys hear me okay?
Yes.
Yep.
I can't hear you. Just, let's see if this works. Can somebody talk one more time just so I can hear? Maybe that works now.
Good morning. This is Sorhai.
Yes, thank you. Now it's working. Appreciate it. Thanks, Tulsi. I had to upgrade the system, so let's see, where's my share screen? All right. So let's see, do we have most people here? So who is Zahut 01?
It's me. Sorry. Freak.
All right. Okay. All right. Let's get you can see the screen here, right? The big one. Yep.
Yes.
Okay,
Thank you.
great. Thanks. Okay. So since we're early in the year, we're going to start off with some comments about drugs again. So today we're going to do 1B agents, which are lidocaine, mexiletine, and phenytoin. And I'll remind you that if we look at the action potential, these agents will shorten the action potential in roughly this manner, as the dotted line suggests. They have relatively little effect on rapid sodium channels at normal heart rates. Generally speaking, the action potential is larger in the ventricle than the atrium, and so the effect is more profound in the ventricle, but it can have effect. These agents can affect the atrium as well as the ventricle, but mostly they're used for ventricular problems. So the first of these agents is lidocaine, which is still an important agent for ventricular arrhythmias in children. It suppresses automatic arrhythmias and rhythms, and suppresses early after depolarizations. This medicine is eliminated in the liver, so patients with liver disease have to be careful with this. And the half-life is relatively short at 1 to 4 hours. Again, as all class 1 agents do, it shortens the action potential in the ventricular myocyte and suppresses abnormal automaticity. And this is important because patients who have a heart block after open heart surgery, for example, who may have a ventricular escape rhythm, if you give lidocaine to these patients, you may actually cause asystole because the escape rhythm can be suppressed by lidocaine. So be careful with that. If you ever have a patient who has heart block, who also, by the way, is having ventricular ectopy, that could be a potentially dangerous combination, lidocaine and heart block. So make sure you have properly functioning pacemaking wires if you're going to do that. It has almost no hemodynamic effects, which is nice. And again, clinically, we use this mostly for ventricular arrhythmias, but it's important to remember that lidocaine can terminate SVT in up to about 15% of cases. And although we would never use it for SVT, now right here, it's not the first, second, or third line therapy, it sometimes can terminate SVT. So sometimes I've heard people say, well, it broke with lidocaine, so it must be ventricular. And I would say if it breaks with lidocaine, it is probably ventricular, but it is not definitively ventricular. So keep that in mind when you are using this agent. Okay. Side effects are very important with lidocaine, and definitely everyone in this conference is going to see this at some point. And these include seizures, paresthesias, visual disturbances, slurring of speech, dizziness, perioral numbness. Adult or patients who can talk to you will tell you they don't feel great when they're on lidocaine. It absolutely can cause seizures, and different patients have different thresholds for seizures. So it really just depends on the patient, but you have to be careful. And so you don't want to really push this agent too quickly, because for sure you can cause seizures in most patients if you try hard enough. Phenobarbital will lower lidocaine levels. So typically we need higher amounts of lidocaine in patients who are on phenobarbital, and propranolol will raise lidocaine levels. So patients who are on propranolol need less lidocaine. So those are important interactions. Moving along, Mexiletine, we should, sort of generally electrophysiologists and cardiologists think of it almost like oral lidocaine, because it has similar effects electrophysiologically. It is well absorbed from the GI tract. It is also metabolized in the liver, and it has a much longer half-life of 8 to 16 hours. And because of that, it has to be dosed every 8 hours in kids. Like lidocaine, it shortens the action potential in ventricular myocytes. It suppresses abnormal automaticity. Again, it can cause asystole in patients with ventricular escape rhythms, and it suppresses after depolarization. In terms of clinical uses, it's interesting. In the old days, when we didn't have defibrillators and people were very interested in whether medicines were effective for people with serious ventricular arrhythmias, they would take the patient to the cath lab. They would induce VT, defibrillate the patient, or VF, and then they would start an agent and then reattempt. And it turns out that Mexiletine is reasonably good in suppressing ectopy, but it really only is successful 5 to 10% of the time of suppressing inducible arrhythmias in the cath lab. So it's not a very potent anti-arrhythmic agent. It's generally never used to treat ventricular arrhythmias alone. One of my mentors used to say that Mexiletine was good at treating Holters, not so much at patients. So you would never use Mexiletine as a single agent for most patients who have ventricular arrhythmia, with the possible exception of patients with long QT syndrome type 3. But even in those patients, it is usually used in combination with a beta blocker. And again, it's the long QT type 3 patients who sometimes, not all, but some benefit quite substantially from the use of Mexiletine in combination with beta blocker. It has no side effects hemodynamically. Again, it has a lot of CNS side effects: tremor, blurred vision, ataxia. It is definitely an agent that can cause nausea, diarrhea, or vomiting, so GI complications are concerning. And then levels are lowered by phenobarbital, like lidocaine, phenytoin, and rifampin, and levels are raised by INH and chloramphenicol, which is not really used very often anymore, but rarely we do use it. Okay, and then just for completeness sake, the last of these class 1B agents is phenytoin. Phenytoin today in the present era is rarely used as an anti-arrhythmic agent, much more as an anti-seizure agent. It was touted in the late 80s and early 1990s as being excellent for ventricular arrhythmias in children, but there really are very, very limited data to support this. And in the present era, it's almost never used. Maybe the only indication for it for ventricular arrhythmias would be for patients who have digoxin toxicity. It's considered a pretty good antidote, or at least it's good at treating the ventricular arrhythmias associated with dig, although probably lidocaine or Mexiletine are equally good for that. It's interesting how this agent ever even got used for ventricular arrhythmias. In the very early stages of pediatric electrophysiology in the late 80s, there was basically one guy who was interested in pediatric electrophysiology, and he said to everybody that this was very good, and essentially based on his recommendation, because he was the only person interested in EP at the time. Oops, I don't know what I just did there. That was recommended, but in fact, today nobody really uses it for that indication. So it would be very rare to see a patient treated with phenytoin in the present era. Okay, so any questions about 1B agents before we move on to some unknowns? Okay, so let's move along. All right, so this is a tracing from a 1-year-old who had tetralogy of flow surgery and is post-op hour 2. So why don't I ask Maya what she thinks is going on in this tracing?
Okay. So, I
apologize.
don't,
A little fuzzy, but it's clear enough, I think.
yeah. So I don't see P waves, so I don't think it's a sinus rhythm. And I think the QRS looks wide. Well, yeah, it does look wide, not necessarily in all the leads, but in a lot of them.
Anything else about the appearance of the QRS? Does it have a right bundle morphology, a left bundle morphology?
I think it has a little bit more of a right bundle.
Yeah, I'd say a lot more of a right bundle, right? This is a very prominent R wave. Here we have an RSR prime. So this is maybe an incomplete right bundle, but probably just makes it to a right bundle. Okay. So what else do you think? What do you think is in your differential in your mind? So you're 2 hours after tetralogy surgery. You're in the ICU, and the physician assistant has handed you this tracing. So
I guess post-op complications include jet. So I think probably maybe a jet with a incomplete right bundle.
Right, absolutely. This could be jet, and could also be VT, right? Because you don't really see, the problem is when you have a wide QRS, you could compare it to the preoperative tracing, right? But the problem is the patient's had surgery, so there may be some injury to the conduction system related to the surgery. And as we know, right, tetralogy patients often will have a right bundle after heart surgery. So we don't know if this is the usual or not. So let's just very briefly discuss JET today. So JET is a very common automatic postoperative arrhythmia. You remember that we discussed previously that in general terms, there are automatic and reentrant tachycardias, and this would fall squarely in the automatic category. It's mostly seen following complex intracardiac repairs, and the most common ones are VSD or tetralogy of Fallot surgeries. And as is the case with all automatic arrhythmias, they heat up and cool down. They do not typically have an abrupt onset and offset. So when somebody would show me a tracing like this, one of the first things that I would do would be to go look at telemetry and look at the heart rate trend and see, did this rate of, this is like close to 180, 190, was that sudden onset, or did it happen slowly over a period of an hour or two? In this case, we would have anticipated that it occurred slowly over a period of time. And these are very catechol sensitive arrhythmias. And typically we can see this immediately following surgery, but it's not uncommon that patient comes back from the operating room in sinus rhythm, and over the first hour or two or three, it will start to accelerate and worsen. And it is the lack of AV synchrony and the shorter filling times that cause hemodynamic embarrassment in these patients. And to remember, the lack of AV synchrony normally isn't that important, but if you've just had open heart surgery and your cardiac output is substantially lower because of a bypass run, as well as an acute injury to your ventricle, you are going to need every little bit of cardiac output you can have. And the absence of AV synchrony can be very, very hemodynamically embarrassing for a patient. And generally, this is associated with decreased urine output, lower cardiac output, and worsening respiratory status. Now, importantly, in JET, the ventricular rate is equal to or greater than the atrial rate. And so the differential diagnosis when the ventricular rate is greater than or equal to the A rate is, or I should say, when there's more V's than A's, it's got to be either JET or VT. Okay, so it's an important rule to remember about rhythms. When there's more V's than A's, then there usually is either JET or VT. And in JET, you can have AV-VA dissociation or association. So the classic description of JET is that there's VA dissociation, but that absolutely does not have to be the case. Patients can have normal ventricular-atrial conduction through their AV node and can have jet and have VA conduction that's associated or dissociated. So dissociated makes it a little easier, but the bottom line is it can be either. So you have this rhythm, and so you're at the bedside and you're thinking to yourself at 2 a.m. Rob Pass said that if there's more V's than A's, or that the differential here is jet or VT. So how could we prove if this is jet or VT? So let me see if we'll ratchet this up to Dr. Barris. So David, if you were at the bedside, how could you tell if this was VT or jet?
If you atrially pace, you could see if your QRS complex narrows.
Okay, so if the QRS complex were to narrow with A pacing, what would that imply?
That would imply that it was VT.
Right, because in jet, the QRS morphology should look exactly like the sinus QRS rather. So remember that in jet, the other term for jet is His bundle tachycardia. So the His bundle is firing at a rate faster than the sinus rate and taking over the rate. But because the impulse is coming from the bundle of His, which is above the bundles, the QRS morphology should look exactly the same as sinus. So if you were to pace this patient and the QRS morphology were to stay exactly the same, then you would know you're in jet. And if you were to pace the patient at a rate faster than this rate and the QRS morphology were to narrow, as David so eloquently said, that would be suggestive of this being VT. So that would be the way that we would distinguish between one or the other. Now, there are basically two main ways that we can treat jet. There's what I sometimes think of as the old-fashioned way or the more novel way. So the old-fashioned way, which is true for everybody, first of all, we would always minimize inotropes because this is an automatic arrhythmia and inotropes will stoke the fire of the arrhythmia. We want to maximize the use of sedation as much as possible because any internal adrenergic tone can enhance the arrhythmia. So you want to make sure that your patient is really asleep. And particularly Precedex has been reported in many case reports and studies now to be an effective agent even for treating jet, probably because of its very powerful sedative effects. And so Precedex is not uncommonly used in the treatment of jet, and it's probably because it's so commonly used today in postoperative patients, probably part of the reason we don't see as much jet as we once did in the past, but we still do see it. It's always important to normalize all of the electrolytes, and of course, you're always taught to check everything, including the mag and calcium, but I'll be honest in saying it's exceptionally rare that I've observed those to be abnormal in this setting. Now, in the old-fashioned approach, we would cool the patient to 35 degrees centigrade. Now, whether one is going to use a more novel approach, which is going to be amiodarone, or the old-fashioned approach, keeping a patient cool is always a good idea. At the very least, we never want a patient with jet to be febrile. So whether we were going to use amiodarone or use procainamide, we would always want the patient to, at the very least, be normothermic. However, if we're going to go this route of the old-fashioned approach, we would want to cool the patient down to 35 degrees centigrade. And it's very, very important that cooling a patient be done very carefully. Typically, we will do it with a cooling blanket, and we usually will have a continuous temperature monitor because it's very easy to overshoot and make a patient too cold. And if you make a patient too cold, you will lower the fibrillation threshold and you will get VF. In fact, that's part of the way that surgeons stop the heart to do surgery, right? They cool the patient down and then they fibrillate the heart and the heart stops beating. We have to be very careful. You really don't want to go much below 35 degrees centigrade, and it's very easy to overshoot. So that's why you want to have a cooling blanket with the ability to change the temperature at any time. And you really want to have a continuous monitor, whether it's a rectal thermometer that's on the monitor or something along those lines. Some of you have heard the story I've told when I was a resident. They didn't have cooling blankets in the early 1990s, and we would cool patients by gastric lavage with water. And that was really terrible because We could cause all kinds of electrolyte abnormalities, and it was very, very difficult to control the temperature. You would typically overshoot quite substantially. So that was, in retrospect, very, very dangerous. We thankfully got away with it whenever I did it, but really is a terrible way to cool patients. Today, we would use a cooling blanket. And when a patient is cooled, it's very important that they be very heavily sedated. And some people would say even paralyzed, because we don't want patients shivering, because that's a use of cardiac output that we don't need, and will take away from perfusing things like your brain and your kidneys. So if you don't paralyze such a patient, you want to make sure that they're very, very heavily sedated so that they don't shake and are uncomfortable. And then once the tachycardia rate falls with this, you'll try to atrial pace the patient above the rate in order to gain AV synchrony again. Now, sometimes some patients, let's say that we have the patient we're talking about today, who comes in with a rate of 190, and we cool the patient, let's say, down to 165. Now, some patients in junctional rhythm at 165 may in fact be better hemodynamically than if they're apaced at 170. So you have to pace and look at the hemodynamics over a period of a couple of minutes in order to see if you're observing an improvement in cardiac output. Sometimes you'll just leave a patient junctional. More often than not, apacing will be a better solution, but not 100% of the time. And then if you still don't have control, you would give IV procainamide. And typically the dose is about 10 to 15 milligrams per kilo given over 45 minutes, and then a continuous infusion of 20 to 40 mics per kilo per minute. Now, more commonly in the present era, people are giving smaller doses. So they give about 5 per kilo, about every 15 to 30 minutes. And the benefit of this is that procainamide can cause vasodilation and hypotension. But if you give it in a dose of 5 per kilo, it's less common to see that, and you want to give it pretty slowly. So you would give 5 per kilo, maybe over 20 to 30 minutes, and then reassess, and probably have to give dose 2 or 3 times sometimes before you see adequate effect. This approach is actually the only approach that is almost universally effective. And it's been studied many, many times in comparison with the next approach, which is IV amio, and by far it is the most effective approach. It is not, however, the most commonly used approach because it involves sedation, it involves cooling. Both of those things enhance mechanical ventilation time, increased risk for all sorts of other things associated with being intubated, like ventilator-associated pneumonias, pressure sores. By definition, if you're cooling and sedating someone so heavily, they are going to remain intubated longer. And you get all of the associated morbidities with that. And so it isn't a free ride to do this, but this is in fact the most effective approach according to the literature. That said, today, the most commonly used approach is using amio or amiodarone. So again, we would minimize inotropes, we would maximize sedation, normalize all the electrolytes. You don't need to cool a patient for amio. That's probably the most important benefit of amio over the IV procainamide. Because remember, procainamide, if you're going to use it for the treatment of JET, the patient must be cooled. It does not work in a normothermic or in a hyperthermic patient, but amiodarone will. So it's good practice to get people who are on amiodarone, in whom you're going to use amio, to be heavily sedated and to be normothermic, but you do not actually need to cool them. And so typically we would administer 2 to 5 per kilo over 30 to 60 minutes, followed by a continuous infusion of 10 per kilo per day. And I've written here to beware in infant boys. That's because there is some data to suggest that the tubing that it goes through leaches plastics out of the tubing that can be bad for the testicular development in boys. So in animal studies, there's been evidence of potential danger for that, although not so much in children, to my knowledge, although I don't really think it's been studied. So some people would prefer to give this, rather than a continuous infusion, to give it in a Q6 manner to reduce the exposure of the agent to the tubing to the patient. And I would say this agent should never be given without ventricular pacing wires because sometimes amiodarone can cause heart block. And so you want to make sure you have the ability to V-pace, or else you may, in the setting of someone who has maybe some minor injury to their AV node from surgery, you want to make sure that you can pace the ventricle as well. So does anybody have any questions about JET or treatment of JET?
Yeah, am I recalling correctly? Have you mentioned to us about IV sotalol use as well?
Right. So IV sotalol is probably going to become option 3. I'm going to have to change this talk soon. So some people are starting to use IV sotalol for JET. And the theoretical benefit of this is it may have a faster onset than amiodarone, and it does not seem to cause, what is the biggest concern with IV amio is cardiovascular collapse, particularly in young infants. It is an idiosyncratic reaction, but it can happen. And when it happens, usually the only treatment is CPR, high doses of inotropes, or ECMO. And I think some of you may remember we had a case of a patient who arrested and needed to go on ECMO transiently because of amiodarone infusion. So it can happen. And that has never been described to my knowledge with sotalol. So at the present time at Mount Sinai, IV sotalol is not on the formulary, but it is actually coming before the board for the hospital very shortly. So we will probably have this agent as an option in the near future. And when we do, we'll discuss it in greater detail in terms of how to use it and in whom it would probably be most useful. It's still sort of an agent that a lot of studies are showing efficacy in small studies for different arrhythmias. It's not clear yet exactly what the best place is for it. Many of you know I'm not a huge fan of IV amiodarone for JET. The main reason that I'm not is because, quite frankly, the data on its efficacy is not spectacular. And for sure, the incidence of serious side effects associated with IV amio is quite substantial. Like in some of the better controlled trials, probably about a third of patients who get IV amiodarone have a serious complication, whether it's cardiovascular collapse, chemical burns related to the peripheral administration of the agent, hypotension requiring escalation in inotropic support. There's definitely a very high incidence of side effects associated with IV amio. So my general approach is that if I do not need to use IV amio, I'd rather not. But obviously there are times where it has absolutely saved patients' lives. It's a good medicine, but it has to be used judiciously. Any other questions?
Dr. Pass, like you mentioned, please, for the amio, like your preferred dose, if you use it for the JET, will be like over 1 hour and sometimes even longer for the loading dose?
I mean, a lot of it depends to some degree on how ill the patient is, right? So if someone is really, really sick and has a heart rate of 220 and you need to get that down quickly, you would be more urgent in your administration. But in a perfect world, I personally like to give 5 per kilo over like an hour or an hour and a half. And the reason that I prefer that is because maybe I'm wrong in this regard, but I kind of feel like if you started to see hypotension associated with its administration, you might be able to catch it and stop the infusion before you have these more serious side effects. So that's the main reason that I like to give it slower, is so that if there's any appearance of a problem associated with its administration, you could minimize the amount that is given. Some electrophysiologists and intensivists will give 2 per kilo as little mini boluses. Some of you remember that when Dr. Rossi was here as our visiting professor, he has told me that he typically would give 2 per kilo, watch for 10 to 15 minutes, see what happens, and then go again. And he claims that 1 or 2 doses very often is effective. That said, that has not been my experience. When he told me that he did this, I tried this in a handful of patients. I did not find it effective. I should also mention that at his center, they very, very rarely see JET. So I don't know, it may be that his patients are a different substrate than ours, because, for whatever reason, their surgeons don't seem to almost ever have JET. I mean, obviously we don't get a lot of JET either here, but we do see it on occasion. So any other questions?
Thank you.
Okay, so let's go over one more tracing here. So this is a 6-week-old with tachycardia, and this is a tracing on this patient. that was obtained on a monitor. So the question here is this jet, and why or why not? And what would be the treatment for this? So let me see if Dr. Kong, I see you hiding there in the background.
Good morning.
Good morning. How are you? I'm gonna,
Good, how are you?
even though I know you're an imager, we'll ask you an electrophysiology question today, since your boards are coming up soon.
Yes. So I'm looking at the QRS complexes, and there does seem to be a change in the QRS complex. There are those 4 beats in the middle where the QRS is narrower, and there seems to be some kind of relationship with the P and the QRS, which does not seem, there seems to be dissociation in the wider complex QRSs. The wider complex rhythm is slightly faster, I think, but it's really not that fast, like maybe 140. So I would probably call it an accelerated ventricular rhythm. I wouldn't call it jet because the QRS complex appears different from what I assume is the sinus rhythm in the middle.
That's exactly right. Very good, Grace. Ready to take your board exam. So yes, when the sinus rate accelerates ever so slightly faster than this rate, we see that the QRS, as you said, narrows and changes from the other QRSs. So if this were jet, then the acceleration of the sinus rate with transient AV synchrony would not cause a narrowing of the QRS. Just like David told us earlier, when a patient has jet, the QRS morphology should be the same as the sinus morphology, whereas in VT it is different. So this is an example of a VT, or an accelerated ventricular rhythm, as opposed to jet. And so this patient, at 6 weeks of age, one would want to look at a lot of different things in determining whether to treat an accelerated ventricular rhythm. The first thing, what would you do? So if you got this monitor back, Grace, what would your first thing you would do be in terms of evaluating this patient and determining whether you want to treat this?
I would assume the patient is hemodynamically okay since the rate is not that fast, but I would get an echo.
Right. And why would you get an echo?
To look for any reasons why this patient would have a ventricular focus, like tumors, for instance, can happen, or I guess underlying congenital heart disease. But also, I wanted to look at function. I mean, he's 6 weeks old, so I guess I would expect the function to be normal, but I would also look at function.
Right. Definitely, you would want to look at the function to be sure that there's not dysfunction on the basis of like a tachycardia-induced cardiomyopathy. You could look for these little Purkinje tumors, which I've never seen in any patient in my career, but that may just reflect that I've never just been in a center big enough maybe to see that, although I have been in some big centers. But the bottom line is, yeah, you would do that. And if the patient, what would be the natural history of this, do you think? So the mother says to you, is this going to be a lifelong problem for little Bertha?
And there's nothing, the echo was normal. I didn't see anything on echo.
Correct.
I think the natural history would be good for the patient, that it would eventually get better.
Yeah, this tends to resolve in the vast majority of patients. So we would follow this patient closely. Some patients would treat this with a beta blocker on the theory that it would preferentially slow the VT rather than the sinus rate. I guess it would depend on what the average heart rates were, but if this patient had normal average heart rates, say 120, 130, 140, I probably would just carefully follow this patient. Obviously, I would get a 12 lead, make sure the QT interval is normal, preferably in sinus rhythm to measure it. But if the QT was normal and the function was normal, I'd probably keep a very close eye on this patient, their growth, their development, and most importantly, their function, and probably go from there. Okay. So I think with that, we'll stop this morning. Thanks, guys, for joining. We have on Thursday, just to remind everyone, we're going to do angiography review. Sorry, we missed 2 weeks ago when I was on vacation, but we'll do it this week if you guys are available. Okay. All right. Hope everybody has a great day. See you
Thank
soon.
you.
Thank you too.
Thank you.
Thank you.
Bye-bye.